So in this lecture, I'm going to talk about identifying complicating conditions, and as the title implies, these are conditions that can complicate our ability to get accurate test results, and they're problems that can complicate our ability to, or our patient's ability to fully engage in treatment. And I am going to go through these relatively briefly. Again, some of this, for example, some of the visual issues we've talked about in CD558, such as visual field cuts like a homonymous hemianopsia, which is essentially a blind spot in one half of the visual field that happens after stroke. So in general, when we get a consultation, and particularly for a patient with aphasia where they may not understand language very much, as speech pathologists, we want to know how their hearing is, right? Because certainly people can not understand us because they have aphasia. They cannot understand us because they're not hearing us well. But probably more often is that when you have some degree of aphasia and some difficulty following what people say, layering a hearing impairment on top of that just simply makes the listening task more difficult, and these individuals are even more vulnerable to breakdowns in following what people say. As far as testing, when we're in our quiet room, of course, we may be able to modulate our loudness, and so it's not a problem. But when we're evaluating people up on the medicine wards or something like that, we need to take that into consideration. And for people in the acute stage, they've just had their stroke or something like that, we would probably not recommend an audiology examination, because quite honestly, we're not really going to start treating them until they go down to rehab. So once they get medically more stable, and when people go to rehab, that is a sign that they're medically stable. Then if it's been a year or more since they've had a hearing test, we could request that the rehab physician order that. Oftentimes what you'll see is that patients have hearing aids that they left at home because in the rush to get to the hospital, they weren't brought along. And so sometimes it's as simple as asking the wife, if your patient has severe aphasia and can't really communicate that, asking the wife whether or not there are hearing aids at home, if she can bring them, etc. Unfortunately, what you'll also find is that when patients move from room to room, things like hearing aids and dentures get lost. And our audiology clinic in our hospital had a box full of spare hearing aids. If that's a little funky sometimes, just because, the minimum the audiologist would have to make a new ear mold. More commonly, what I'll do is bring along a little pocket speech amplifier so that I can put headphones on my patient and I can talk into a mic, and that will amplify my voice. Vision problems. These are things that both the hearing problems and the vision problems are not really things that I think we screen for per se, although if you wanted to go so far and do that, you could. We end up making referrals to audiologists and optometrists because we see things during testing and we suspect that these issues may be due to some kind of perceptual problem. I mentioned here briefly the agnosias. I have to say they're fairly rare, and so I'd like you to know what they are, but I can't remember the last patient I saw that had a clear-cut agnosia. Agnosias often require bilateral brain damage to very specific areas of the brain, and so that's why they're not so common. More commonly, what we'll see in terms of vision is, as I mentioned, a homonymous hemianopsia, a field cut, hemifield cut, blind spot, for another way to say it. More often than not, patients compensate for that on their own. We talked a little bit about left neglect, which is not a perceptual problem, really. It's a attention problem, but it certainly affects people's ability to make use of whatever visual information we present to them. And of course, the signs of left neglect are oftentimes quite clear, in the sense that people very reliably ignore words on the left side of the page. They only eat the right side of the food on their lunch tray, etc. Moving on to the motor impairments, and again, you'll have a class, CD660, on apraxia of speech, so we won't go into too much detail here, except to make a couple key points, and that is that very, very rarely will you ever see apraxia of speech in isolation. I've never seen it in 20 plus years, and many of my colleagues haven't either. More often than not, 90% of the time, apraxia of speech co-occurs with aphasia, particularly aphasias where the left frontal lobe has been damaged, because of course that's where the motor association cortex is, that's where motor planning happens. So we see apraxia of speech go along with non-fluent aphasias like Broca's aphasia and transcortical motor aphasia, and very often times with global aphasia, because in global aphasia the lesions are often very big and more likely to invade these regions that are responsible for motor planning. Although Murray and Clark mentioned some tests for apraxia of speech, I don't ever use formal tests for apraxia of speech. None of my colleagues that I can remember did. Apraxia of speech is a perceptual evaluation. You just need some simple stimuli, and the book that you'll get in CD660 by Joe Duffy has a nice apraxia of speech protocol right there in the book. But it's a perceptual evaluation. We ask people to do certain things with their speech, and then we listen, and it's what we hear that determines whether or not we come up with a diagnosis of apraxia of speech. So, a standardized test where we get scores and stuff like that, I'm suspect of that approach. Similarly with dysarthria, again, perceptual evaluation. Dysarthrias are going to be more common with TBI and dementia because, of course, if you remember from 558, in order to get a really significant and noticeable dysarthria because of cortical damage, you need bilateral upper motor neuron damage, and that will give us a spastic dysarthria, which we commonly see in after TBI because of the diffuse axonal damage affecting, amongst other things, the upper motor neurons. Occasionally you'll get a flaccid dysarthria because in TBI a skull fracture cuts a cranial nerve. Of course, the subcortical dementias like Huntington's chorea and Parkinson's disease the most prominent feature of those diseases is often the person's dysarthria. Other motor problems, we pay attention to hemiplegia, in other words, weakness or paralysis on one side of the body, to the extent to which it impairs a person's ability to write or to gesture really successfully. And I can't tell you how many patients I've had who have very severe global aphasia, sometimes so severe that really any immediate possibilities of speaking were kind of not really going to happen. And so I was looking at other ways for this person to begin to communicate and reduce their frustration. Well, gesturing is certainly one option, but if you think about it, gesturing with one hand, it's much more difficult to communicate a wide range of concepts. How do you communicate big with one hand? Small is easy, but it's easier to do big with when you have two hands available, and so on. Patients, besides hemiplegia, weakness in the limbs, can have apraxia that affects the limbs. And so, again, this is a motor planning problem. It's not that apraxia of speech doesn't have anything to do with whether the limb is strong or weak or anything like that. It has to do with whether or not a patient is able to plan out the different movements required to achieve whatever goal they have in mind, whether that's brushing their teeth or doing a gesture. And so limb apraxia can I've had patients who, because of their limb apraxia, they had global aphasia, and the limb apraxia, because it will show up in both limbs, even if the damage is only in the left hemisphere. We tend to get limb apraxia mostly from left hemisphere damage rather than right hemisphere damage, but it shows up in both hands, which suggests that the left hemisphere is dominant for this kind of praxis motor planning capacity. I've had individuals with significant limb apraxia, and so gesture wasn't an option, and even the limb apraxia was so significant that using other alternative communication devices like a communication board, AAC device, was difficult because they had difficulty even pointing accurately. As far as screening for psychiatric disorders, it's really something that I've never seen an SLP do in a neurogenic population, except one friend of mine who I greatly admire her skills, but she sees a special population. She specializes in individuals who've come back from Iraq and Afghanistan war with mild traumatic brain injury. And these individuals often have a host of other factors that could be affecting their cognition besides their mild traumatic brain injury, post-traumatic stress disorder, and the psychiatric complications of that, poor sleep, chronic pain, etc. So often, my friend Leslie does use some devices to screen for something like depression. And of course, we're not responsible for making those diagnoses, really, and I've used some of the instruments that your authors list in table 5.3 in your text, particularly with regards to depression in people with aphasia, because depression is quite common after stroke, and particularly left hemisphere stroke. I've used them. If a person, for lack of a better word, fails this screening instrument, which usually they don't take very long to give. We're talking about oftentimes 10 or 15 questions that are answered. Sometimes the questions can be asked of a caregiver. And then if the person scores and it suggests that they may have an issue with something like depression, then I'll contact the physician who referred the patient to me, asking me to treat him or her. And I'll say, well, Dr. Smith, I suspected just from casual observation that my patient was dealing with some depression, and I didn't notice in the medical chart that he had been identified as having a depression or was taking antidepressant medications. I'm concerned that this possible depression is going to negatively affect his ability to really take advantage of our treatment time together. Could next time you see him, could you take a look at him? And doctors are very happy to do that. The Murray and Clark mention apathy briefly, but they don't list apathy scales in Table 5.3. And I think more and more I'm coming to understand that apathy is an important thing for us to be aware of, because it is a neurologically based demotivated state. And of course, motivation is the foundation, one of the foundation ingredients of a person doing well in treatment. And apathy is fairly common in the dementias, both cortical and subcortical, like Parkinson's disease. Apathy is quite high. And I can't tell you how many times before I became aware of apathy, I would be treating someone with Parkinson's disease with a treatment called Lee Silverman Voice Treatment Program, probably the most popular one out there for popular treatment for individuals with dysarthria. And part of a big major component of this treatment is that it's intensive. We see patients for 4 to 6 weeks. We see them 4 days a week. But even on the days that we see them, the patient is supposed to do a half-hour of practice on their own. On the 3 days that we don't see them, they're supposed to practice twice a day. And so many times I've seen patients who, even though intellectually they had the good intention, they just didn't manage to do their home practice. And of course, they suffered from that in terms of doing well in the treatment. Or they, despite not doing all the practice, they improved because I was seeing them 4 times a week. But then as soon as I discharged them, they did not maintain their maintenance practice, which is required, because Parkinson's disease is a progressive neurological disease. So now that I'm aware of apathy, I definitely look at that. And for my patients who have apathy, I will rearrange treatment a little bit different, and I'll talk about that when we get into talking more about motivation and treatment. Finally, I'll just say that some authors have written about what is called linguistic anxiety in people with aphasia, and that's essentially anxiety about speaking to others, right? And which is very understandable. If you're someone who's really struggling to speak, then particularly when speaking to strangers, you may feel some fear, apprehension, and stress. And there's some authors, we don't really know to what degree this affects people's actual language performance, but some people speculate that it can, and it's a fairly new area of investigation in general. But I think that in my experience, for some people it does most definitely affect their performance. And we only have to pay attention to our own experiences and realize that, when we were giving a public speech or something like that, and we were experiencing a lot of anxiety, that we weren't as fluent as we could be. We may have made more speech errors. We may have forgotten to say things we intended to say, etc. The other thing about linguistic anxiety is that it can simply prevent people with aphasia from leaving the house and becoming more socially engaged. I don't know of any good instrument to assess anxiety in people with aphasia, but again, I think this is something when we have a good relationship with our patient, and just through having a lot of communication, and we can tease these issues out. Okay, so that is it for complicating conditions.